I want to invite Kambis. Kambis, I think we joined a webinar together with you, and that was a fantastic. And I watched your amazing presentation. Kambis, you have a huge fan base. I don't know if you know, but you have a growing fan base in Turkey. I have visited Iran recently, and in Iran, everybody loves you. And it's always a pleasure and privilege to be with you in a webinar. He will be sharing his tips and tricks for a successful retrograde CTO recanalization. Kambis, the floor is yours.
So thank you so much for the very, very nice introduction, which makes me really very happy. And I really enjoy also to come to Turkey and Istanbul. And I hope that once the situation COVID will recover again, hopefully soon, we will see each other again in real life. So now change from imaging to retrograde CTO PCI, and I will also just focus a little bit also on imaging. You will see why. And this is about tips and tricks for successful retrograde CTO recanalization. And I'm not talking now about absolutely basics about CTO retrograde CTO problems. So I'm speaking even about a little bit more advanced problems. You will see what I mean actually. So first of all, I want to focus on the analyzing of the collaterals. I want also to speak about failure of retrograde microcatheter passage. So what to do if the retrograde microcatheter is not able to cross. And I want to focus on the reverse cart and on the externalization process, which are major steps of retrograde CTO PCI. So now about analyzing collateral connections. I will just show you what about we have actually from the data. The first publication was in 2009 from Sruthi Rathore, who is now in England. And at this time, he was in Toyohashi Heart Center, and he was following Osamu Kato, who started already with retrograde PCI at this stage. And so from this time, he analyzed 150 patients on retrograde CTO PCI in retrograde success and failure. And what he has seen there was very interesting, because those are the problems we face on today also. So the septals seem to be more easy than the epicardials, which are more likely to fail. And if we have a good visible channel, it's also more likely to pass. And if there is no tortuosity, it's also more likely to pass. It's different when you have a Cruikshank type, then it's very difficult to pass, right? And also the received angle, vessel angle, does have an impact. So nowadays, 2018, we have now at least 3 publications out which are focusing on channel crossing. And one of the publication which was simplifying everything was actually from Xingruan Huang, and the chair also of the publication was Paul Xingling Cao. So Paul Cao from Taiwan. So what he analyzed here was that there are 2 predictors for collateral failures, and this is the large of the vessel size and the lack of tortuosity, and both were predictive in a univariate and multivariate analysis. So what he could find out, it's a scoring system. So if you have a large collateral, CC2, you get a point. And if there is no tortuosity, you have 2 points. So it's a 3-point collateral score. And what he found out is actually, if you have 2 or 3 points, the likelihood of passage is more than 90%, which is perfect. But if you have no point at all, it's very likely that you will fail to pass this collateral. So it's only if the collateral is big and if you have no severe tortuosity. So there was another publication which I reviewed on the G channel score in neurointervention this last year. It was the first time, it was also with Osamu Kato, who was one of the seniors of the paper, where they focused on septal and non-septal collaterals. And it is a little bit more complex score, but it's near to the score we know from the G-CTO score, and therefore called G-channel score. And if you have a scoring system, it's 0 is easy, like in the G-CTO score, intermediate is 1 and 2, and difficult is 3. And the determinants are actually large vessel size or small one, and reverse bend, a continuous bend, and Cockshire type. So those are the types so when the septal connection is very small, you get a 2 point. When you have a non-septal, which is very small, you get even 3 points. And if it's Cockshire, you have already 4 points. And then they made an estimate of passing rate. And what you can see here, all those are easy. You have over 90% passing rate in septals and over 85% passing rate in non-septal collaterals. So if you have a score from 0. And this gives you a little bit an idea about how to look on collateral channels. For sure, there is also an inter-observer variability, but it helps us a little bit more to understand collateral channels. So I show you now a very simple example. So those are beautiful collaterals. And if you start with retrograde PCI, you should go for such kind of cases. It's not very often, but it's also not so rare that you have such scenarios where even a workhouse wire with a little gentle handling may pass. And here you can see actually that the G channel score is 0 because we don't have small, we have big CC collaterals, we don't have bands, right? So they're very likely to pass. And the Huan score is 3 because we have big collaterals, CC2, and no tortuosity. So the chance is very likely to pass also on the score. And once you go retrograde, you have to understand where you go retrograde. Which vessel do you want to attack? So sometimes you almost, when you go retrograde, you want to go into the PDA. The PDA is almost collateralized by the mid-septal, so we call it S2 or S3 connections, distal septal connections. So those mid-septal connections are actually one of the best connections. The distal septal have the problem that there is often a very huge angulation. You have to be aware of this angulation there, that there will be not some shear stress or rupture of the channel while you pass with your microcatheter or you have your externalization process. And the proximal channels can sometimes end up in the posterolateral branch. So if you have an additional problem that you don't get the posterolateral branch antegradally, you can even go retrograde, and you have to look at these connections from the very, very first septal connections. So I show you now how we deal with retrograde collateral channels. Here you see very nice connection, and this is how a CM blue workhouse wire just goes into the channel, and this we call septal surfing. You can look at my hands and also on the video. For sure, I'm doing this every day, so I'm a little bit faster, a little bit more trained, but I just feel the wire, I just go for the wire feeling. And if I feel a resistance, I stop immediately. So this is how I deal with septal crossing. And here you can see how we deal with the microcatheter. If you look at my hand, it's just a rotational movement. So you rotate the microcatheter counterclockwise in this scenario and push with your other hand your device forward. And this is how you can place very nicely a retrograde microcatheter in the PDA. So the one is the septal surfing, and here you see the connection is already visible, right? So this is a straightforward connection. You can see again how I just go forward and back and just stop if I feel some resistance. So I don't push the wire. The wire is never, let's say, knuckling or destroying the channel. This is very, very important once you start with this, that you just feel the wire should be free and there should be not a big resistance. So it's a little bit different once you pass epicardial collateral connections, right? So therefore, because once they are ruptured, you have a big problem, and it may turn out to tamponade, and in post-CABG patient, even to a dry tamponade, which is a compressing hematoma and may be really a lethal problem. So this is a very complex CTO, actually, with a huge epicardial connection. So those big connections are sometimes not the best ones to go for, because they have a lot of friction, because you have so many tortuosities, and it's such a big connection over many years that this tortuosity will stay there. It's not that it's straightened, and therefore you won't have any chance to bring your microcatheter down there. So therefore you have to find a different connection. And what you can see, the difference between the left and the right is that on the right image, we see even a better view of the diagonal connections. And on the left image, we don't have this. The difference was only that we increased the flow and also 80 milliliters, because of the whole left system was on, whole the heart was on this left system. And then we could analyze very nicely those collateral connections. And here you see some tortuous connection, which are acceptable and accessible for retrograde approach if you're for sure routined and trained, and if you have also a bailout option if something happens there. So here you have to be very careful once you tackle this kind of connections. These are CC2 connections. There is some tortuosity inside, so it's more or less Huon score 1, which has a intermediate chance of passing, right? So, or relatively, you see, so 77%. Here you see the tortuosity. And this is what we always do. It's a super selective injection. So we go inside the channel and then we aspirate blood. It's very important to aspirate the blood whenever you give a flush in the microcatheter. Because if you're flushing the microcatheter outside, you will see how much power you have if you flush the microcatheter. So imagine you are somewhere in a side branch of an epicardial and you flush it, you will have a perforation. So therefore, you have only to flush it if you have a backstream of blood. So we do aspiration. I look if blood is coming back. If blood is not coming back, I never flush. I never give contrast. I go back with my microcatheter until I can see that blood is coming back. Then I give a super selective injection. And here you see a very tortuous channel. So the passing rate is not so high, 50-50, let's say the chance. It depends a little bit on your luck and also on operator's experience. And this is my method of how I pass in bigger collateral channels. In epicardial ones, I like to use the Suo Black. And here you see I give a short band on it, and then I try to rotate the device. And I don't push the device, I try to only rotate the wire. And once I see it's jumping forward, then I advance a little bit. So it's not that I push actively, I rotate with a relatively high speed. And when I see it's moving forward, then I push the wire forward. And here you can see I had to redirect a little bit the wire tip, and then I was in the retrograde posterolateral branch. So I show you this also in a box case, which I did some years ago with Simon Walsh. Actually, here you see an epicardial channel. And
yeah, the question is where to go up. I think this still interesting. Yeah. Oh, okay, there's a band down.
Here you see the band actually. Yeah. And here you see also on the hands how we try to navigate the wire towards the LAD connection, and now also how the microcatheter can easily actually pass also this connection. So it was clearly that what we could see here actually now, if I just repeat it for a second for you, is first of all the analysis of the collateral connection, and then the microcatheter with a CO blue wire, a CO black wire. And then you see a step-by-step analyzing of the collateral, and here you see the Sion wire here, and just go very, very gently and controlled, and then once the wire moves forward, you just got it. It's a little bit different when you go for very small epicardial connections, and there I really recommend only to do that if you get some experience on it, if you had a proctor with this, if you were trained on this. These are connections which are nowadays possible to pass. Actually, it's crazy, I know, but it's possible. This was a guy with a severe renal dysfunction, and where we put a marker wire as a marker wire for getting, let's say, retrograde access to reduce contrast. So this is what we're able to do nowadays with Caravel and Suo Servo-free. And these kind of connections are able to pass in very routine hands. So just to see you where we push the envelope nowadays already. So what you need once you do this kind of things are coils and microcatheters. This is a coils which fits in your microcatheter. And the combination is actually the axiom or concertino coils, which are used a lot for the fine cross, Carvel, Corsair, and Turnpike microcatheters. So you have here coils from 1.5 to 2 centimeters to 2 millimeter and 3 centimeters, 2 millimeter, 4 centimeters, 3 millimeter and 4 centimeters. So, and it depends a little bit on your experience to get the sizing right. What you have also to understand that this coil is reducing flow. It's not that you occlude immediately. Well, that would be the goal, but sometimes the reduction of flow is already enough to get you have to wait a little bit until the effect is coming, right? So, and those are other coils at Sur from Terumo in Boston, and there you need a little bit bigger microcatheter. It's a 2.8 fresh prograde, but it's more smart to use them because you're working already with those microcatheter in your coronary, so you don't need an additional microcatheter. For sure, you can also inject thrombine. So it's for the aneurysma spurium. We take the same one. We take the thrombine, fibrinogen and thrombine. So we take the thrombine out, and then we give for channel 0.2 to 0.4 cc very gently, and then flush very gently with water, like you know it from the TESH, from the transcoronary ablation of the septum. So very gently and wait, and the effect will be good. So you will have a closure of the vessel. And it's also possible as a bailout to use fat. But the disadvantage is, first of all, you have to understand that fat is floating. So you have to turn your microcatheter, as shown from the video from Manos Prelakis, and then the fat floats in. You get the fat out of your groin. It's not so big deal. And then you have to put it in. But then I would recommend not to flush the fat in, because whenever you flush in a destroyed channel, you will blow up even the perforation. So therefore, after the fat is in the microcatheter, use a wire to try to bring the fat down. Actually, it's not so well controllable as the coils. The coils are really clear. You see them, and I'm not afraid to use a lot of coils, because I mean, if I'm placing somebody 80 or 90 centimeters of stand, millimeter of stand, when I have a complete RC occlusion, so I'm not afraid to put some coils in the patient. The patient's safety is more important than he has some coils in his. I don't see the disadvantage here. Okay. So now we focus on the uncrossability of the retrograde microcatheter. It's a big topic, and it doesn't occur too often. It occurs sometimes in the septal channel. Then we are able to dilate the channel, but it can occur in huge calcified lesions. And this is the problem when you are even antegrade failure and retrograde failure, because the microcatheter can't pass. Like here, very, very severe calcified RC occlusion. What you can see here on the right side is that I already tried somehow to penetrate the antegrade cap. It didn't work with all the things I tried. I tried to dissect the cap, going around, no chance. This was a retrograde contrast, and what you can see here is severe calcification. But I was able to bring the retrograde wire at least up to here, and then no microcatheter passed. But nowadays we have actually balloons which are so small that they can pass the septum, and this is very smart. We have the Ikatsuki, we have 1.0, we have Ryurai, we 1.0, we have Sapphire 1.0, we have Sprinter. So we have many different balloons from all the companies. Actually, now I'm sorry if I forgot a company who's producing low profile balloons, and those balloons are really making our life much easier in CTO PCI. And here you can get access retrogradely and can do retrograde dilatation for your microcatheter, because the balloons are nowadays even better than the microcatheters, right? So here you have seen the crossing profile. Here you dilate the balloon first with 1.0, then 1.5, and even a 2.5 balloon was able to bring over the septum. And finally, I could bring my microcatheter up here. I trapped my retrograde wire here. I was ready for some reverse card. And here, the microcatheter could not pass again at this place. So it's also retrograde balloon and antegrade balloon. So I dilated again retrograde. But you have to be aware, if you have a perforation there, you can't cover it. So therefore, not too high pressure, but just to create some space for the retrograde microcatheter. And here I had a retrograde undilatable lesion. So can you imagine? So here I didn't go with too high pressure. I stopped at 16 because if you have a balloon rupture, you can't treat that from the retrograde part, right? You would never get a retrograde cover stand down. But finally, I was able to do a reverse card. I exchanged my wire to antegrade. I could rotablate the lesion. And finally, after rotablation, what you can see, it was subintimal space rotablation with a balloon angioplasty. I had a perforation there. I had to cover it with the cover stand. And then with a very high pressure balloon on 30 atmosphere, I could crack all the calcium after rotablation. So these are cases which are really at the limit of what we can do nowadays on very, very calcified lesion. It was a distal flush occlusion on the cap. So, and the patient is still actually fine. So we did even a re-angio because he came for his legs 1.5 years later, and he was doing in a good condition. And the RCA, we had to do one drug-eluting balloon, but it was still open and patent. So coming to the reverse card. The reverse card scenario is also very important. So if you want to bring your retrograde and antegrade wires, you want to make a connection, you need the reverse card. And the reverse card actually came up with the Crossair in 2011 and 10 when the Crossair was more and more in use, because there we could firstly go retrograde with a microcatheter and then use different wires. In the past, we could only do the card maneuver, actually. Go retrograde with the balloon and puncture towards a retrograde balloon. So here you will see a reverse card maneuver.
All right, so
this is a huge RCA connection, as you can see here. And there are two knuckle wires, antegrade and retrograde. It's a big, big artery. And finally, the knuckles were overlapping, and you have an antegrade mother and child catheter. And there, after dilatation, you create a space where your retrograde wire can go in this space. So you have an antegrade dilatation here, as you can see. And after this dilatation, your retrograde wire just is able to enter into your mother and child catheter. And then finally, this was a five vessel or something. The huge RCA was open. And so this is how it works. You dilate antegradely somewhere in the subintimal space. You have to be in the vessel architecture, which is very important. And afterwards, you puncture towards this created space with a microcatheter. This is how reverse card works, the interior, right? So wires which are often used for that are Pilot 200 or the Gladius nowadays, or sometimes also the Gaia series. So to go a little bit more into the detail of IVUS to understand when the connection is easy and when it's complex, I want to show you this image. And it looks complex, but it is not so complex once you understand it. So the scenarios here, you have antegrade and retrograde wire. One is red and one is black. So let's say the antegrade is black and the retrograde is red, right? So here, both wires are in the intraplaque position. For this scenario, you don't need IVUS. For this reverse card scenario, you only need the dilatation and the reverse card will work. You dilate over your antegrade balloon, the intraplaque, and then the retrograde wire will follow. Very easy. The same is also here if both are subintimal. So let's say you have an antegrade knuckle and a retrograde knuckle. So both are in subintimal, and you will be able to connect because you dilate antegradely and your retrograde wire will follow the antegrade pathway. So now it's getting complex. If the antegrade wire is intraplaque and the retrograde is subintimal, you have the media in between. So you have to puncture through subintimal space to the intima. And this can happen if you're taking a big balloon, which makes an intraplaque dissection. So your balloon must be so big as the vessel to make an intraplaque dissection. Here you see big balloon and you try to dissect and then to re-enter there. And then it works. So therefore, sometimes you need the IVUS to understand how big can I use my balloon for doing this reverse card. And now we come to the most complex scenario, which doesn't work very well. It is when the retrograde wire is intraplaque, but the antegrade is subintimal. Because whenever you dilate your antegrade balloon, the subintimal space is collapsing. And from the retrograde, you have to puncture towards the intima media complex to your antegrade balloon. And this connection fails very, very often. So if you see this in IVUS and you can read IVUS, the routine operator will change immediately the connection. So let's say you have this in the proximal or distal RCA, you change to another segment of the RCA to get this or even this or this position. So this is why nowadays, once we put the IVUS in, we understand what is the failure mechanism of reverse card, and then we can achieve success because we understand what's going on. And I want really to thank Kimura Asakura and the Japanese colleague, and especially also Sumisuchi Sensei, who really introduced us and learned us this to understand this kind of problems nowadays. Okay, because I'm a little bit late, I will go to the alternative externalization techniques. And the wire externalization is the last step you do on retrograde CTO PCI. So imagine already your microcatheter already passed the CTO like in the image A. Then you place your antegrade wire in the antegrade, your retrograde wire in the antegrade microcatheter. So what you have to do next is you have to bring the retrograde microcatheter in the antegrade guiding. And if you achieve this, normally you take a very, very long wire, which is the RG3 from Asahi or the R350 from Teleflex, for example. These are externalization wires, special dedicated externalization wires. And then you can just push the wire from your retrograde gear towards your antegrade gear. And this is your retrograde in D, your retrograde device, your microcatheter. You have to fix your torquer, and you push the wire until you see here the 6 French guide of your antegrade, guiding catheter. And here the wire comes out. You take the introducer needle, like in the image B, and then put the retrograde wire in the introducer needle, and then you can externalize. We already published this in the about the different externalization techniques in neurointervention. It was the tools and techniques session. I think it's a very interesting how to do complex externalization tips and tricks. Sometimes you have the scenario that you have to snare out your retrograde wire in ostial occlusions, like here. So I could puncture retrogradely, and then I have my RG3, so a very long wire, over 300 centimeter, and then I snare it into the antegrade guiding catheter. Here with Nicolas Boudou, it was a P-radial case, very nicely. And once you have it, you can just engage now your RCA occlusion, which was an ostial instant occlusion, where I even couldn't get my guide seated well. It was unable to intubate, but with the puncture and the snaring, I could solve the problem. Okay, sometimes I was invited on different places and you didn't have a snare, so therefore I started to create a snare, where also Sumisuchi had the first idea, and I only copied it, and but I modified it a little bit. He called it homemade snare, and it was the same concept that I had actually, but on a normal catheter. So I modified it with a mother and child catheter. It's very simple. Imagine you have your own balloon and your monorail part, and the balloon is compressing the wire. Once you pull the wire inside, you will get a very, very big snare. Once you pull back, sorry, when you push, you get a big snare. When you pull back, you get a very small snare. So this is like it is in a mother and child catheter. It's an auto trap of your own wire, and over the monorail part you can push. And this is how you insert this, I called it a cam snare. Yeah. So here you can see the image. You just pull, and then you get a very, very, very small, big snare, the biggest snare you can imagine. And then you pull back, and then the snare is getting small, and you can get the wire. And once you have the wire, just pull your mother and child catheter into the guide, and then you already have finished the connection. You can externalize the whole device, the whole wire. So coming back now to a very complex case to be finalized, it's an circ occlusion, a post-CABG patient with a low ejection fraction. What we had here was an alternative externalization technique. First of all, we had the rotor plate, the ostium here, and then we got in a subintimal position. It was Alexander Abron and myself. We did the case together. finally we couldn't re-enter. Therefore, we went retrograde over the EMA graft. So it's a little bit, it was the last remaining scenario. So you have to be careful, but it was not very tortuous. It was big EMA graft. So a Corsair 150 was chosen and a Xeon Black. I did a super selective injection of the collateral. And now you can see how easily you can pass this epicardial channel. So can you see? So in these scenarios, it's very, very easy. So, and then it was easy just to go the whole way, which we prepared initially with the rotor, into the antegrade microcatheter. And here, the retrograde device microcatheter was not able to get into the guide. But here we could do a tip in. So the retrograde wire is inserted in the antegrade microcatheter. This is called a tip in. Can you see? Now it happened. Okay. So, so what we have to do next actually is to bring the antegrade microcatheter down over the CTO lesion, and then we are done. In this case, it was a little bit more complex. The Corsair got stocked. Corsair got stocked. So then we had to do the same again. I tried another microcatheter. I did a tip in and a fine cross. Worked again. You see, it's reproducible, right? The tip in is reproducible. So then we brought the fine cross down, and the fine cross went till here. But then he also couldn't be advanced, and we destroyed somehow. I destroyed the fine cross, and so at the end, the last option was to bring the archie free. So the archie free outside of the whole, you can see, to engage the guide retrogradely with archie free, and it was possible here, and then to bring the archie free, externalize the whole archie free through the antegrade guiding catheter, and to finalize the case. So this tip-in maneuver can help. In this scenario, it was a little bit more complex because we got an uncrossable lesion actually, but you can see it's a good alternative externalization technique. So when do we need the tip-in and the rendezvous? Well, we need it actually when the retrograde microcatheter cannot pass the lesion. We need it also to save the contrast in some scenarios. We need also it to avoid collateral shear stress. We need it also for alternative externalization techniques after antegrade and retrograde uncrossability. And we need also to avoid conventional externalization in kissing wire position. So these are the scenarios where we need the tip-in technique actually. So to summarize the retrograde CTO PCI, what I can recommend you is first of all, try the septal first and try to avoid epicardials when you start because you're not routined with the coils and everything. So you have to do septal collaterals, and I would say you need a proctor or you have to go to somebody who can proctor you and show how to do it, right? Because there are many steps. It's more complex than TAVI or something, right? Try to dilate with low profile balloons if you have a retrograde uncrossable scenario. If the retrograde microcatheter cannot pass, just try to dilate with a very low profile balloon 1-0 deletion. So use IVUS to understand the failure of reverse card modus. So therefore you have also to use the IVUS for that and to understand the intima plaque, intraplaque lesion and subintimal space. This you have to learn, right? But there are a lot of things on the internet nowadays where you can really see images and learn on platforms like InCathLab how to use IVUS in the reverse card scenario. And for sure, you have to master all the alternative externalization techniques to give you more option, higher success rate. So thank you very much. I'm finished.